We have three excellent moderators, one of whom is busy doing a pacemaker. So I have two wonderful people here, Dr. JP and Dr. Vivek Chaturvedi, to be the moderators for the session today. Ashish Nabar, if he's free from the pacemaker implant, he will come and join us. He sent me a message. He's a friend, so I can joke about him. And over to Dr. JP and Dr. Vivek to start today's proceedings, please.
Vivek, please start. Unmute yourself, please.
Hello. Yes. Thank you, sir. So I think the first presenter is Dr. Velu.
Yes, he's going to present.
Yeah.
Yes,
so Dr. Velu, please start.
Okay.
Velu.
Sir. Yes, sir.
Are you in some? We can't see you. Is there some power shutdown in Tamil Nadu?
Sir, yeah. So, is my slide visible, sir?
Yeah. No. But we can't see you, basically. At least I can't.
Your slides are visible. Sir, Velu was visible earlier.
Yeah.
Right now we can't, but earlier he was seen.
Yeah.
Yes, sir. So thank you, sir. I thank the IHRS committee for giving me this nice opportunity. And I am very much humbled to present this case in front of the stalwarts of Indian EP fraternity. I will go to the case history. He is a 50-year-old male, farmer by occupation, diabetic, hypertensive, and smoker. He had a history of recurrent paroxysmal palpitations, 4 episodes in last 2 years. And the last episode was despite on being metoprolol. But no documented tachy ECG was available. He used to get palpitations while swimming in the river, which he used to like. He liked swimming in the river. And because of these palpitations, he's afraid of swimming anymore. He was evaluated outside in 2 hospitals, echo, structurally normal heart. Coronary angiogram was done twice after 2 episodes, which were reported as ectatic coronaries and minus EAD. So he came to us for his troublesome symptoms. He was taken up for EP study with the intent of RF ablation if any tachy was inducible. This is the baseline ECG. This is fairly normal. Normal PR, no gross pre-excitation seen. And during ventricular pacing, we can see retrograde concentric activation with the earliest A in the his bundle region. And with ventricular extrastimulus, there was a decremental conduction with same concentric activation. And in this patient, we have noticed the HV interval was at around the borderline, 54 milliseconds. And during atrial extrastimulus testing, there was the left bundle branch block pattern with delay in the HV. The HV was around 90 milliseconds, 85 to 90 milliseconds. So this was rate-related left bundle branch block aberrancy with delay in HV. So this monitoring HV, as we know, is very important because in Mahayam also there can be a LBB like activation, but we all know that there will be a reduction in the HV. So this was the first tachy that was induced with atrial extrastimulus testing. So I can call it as a long RP tachycardia with the earliest atrial activation somewhere near the coronary sinus ostium. And this was easily inducible with S3. And soon after, this was the tachy that was inducible. This is a white QRS tachycardia with RBB morphology. But obviously, his is there before the V. So this is a RBB aberrancy. And tachycardia is faster here. And again, the atrial activation remains the same. The earliest atrial activation being somewhere around the coronary sinus ostium. And sometime later, this is the tachycardia, now with left bundle branch aberrancy. Now somewhat the tachy cycle length is slower then during narrow QRS and during RBB aberrancy. So with a broad mind, so I did all the maneuvers. So first is synchronous VPC did not advance the atrial activation, and this was done 3-4 times, and it was convincingly shown that there was no effect of his synchronous PVC on the next day. And ventricular overdrive pacing showed a VAV response with VVI minus tachycardia cycle length of 130 milliseconds. And if you carefully see in the left half of the panel, it takes some time to achieve entrainment. And in the initial few beats, there is varying degree of fusion is also seen. Again, this is one point that goes against accessory pathway related tachycardia, because we know in accessory pathway tachycardia, there is entrainment occurs very sooner, maybe within less than 3 beats, whereas in AVNRT, this entrainment occurs a little later, because it takes a long time to reach the AVNRT circuit when compared to accessory pathway. And at baseline, when para-ECN pacing was done, with para-ECN, with ECN capture, the VA was shorter when seen not with, this is a myocardial capture, the VA was longer, whereas with narrowing of the QRS, the VA also shortened. Thereby, here we can, by these maneuvers, we can somewhat confidently rule out any accessory pathway participation in this patient. And also, atrial pacing done at a tachycardia cycle length showed a consistent VA linking, thereby ruling out any form of atrial tachycardia. Also, VOP also showed a VAV response, and tachy never terminated in A. So thereby comfortably atrial tachycardia could be ruled out. Also, if we see here, during atrial pacing, the AH is longer when compared to AH during tachycardia. So slow pathway region was mapped, and here good signal, we can see a nice fragmented A was seen with good AH, with smaller A and a larger V. So immediately starting the RF ablation, there was good junctions we obtained. And this is immediately after RFA. Just after one burn of RFA, we attempted inducing tachycardia, and we got this tachy. So here the tachy is no doubt, it is a straightforward positive HV tachycardia with A on V activation. So it is most probably a typical AVNRT. But here we can see with S2, there is a left bundle branch aberrancy with prolongation in HV. Also with S3 also, this aberrancy is getting even more prominent. But I'm not sure of what's happening here. Is this a retrograde AV node echo, or is this a coincidental APC that is coming here and that is conducting with a long AH, initiating AVNRT? I think this needs discussion, but to my mind, I think with S3, there is an LBV aberrancy, and this is a coincidental APC that is coming here that is conducted with a long PR and inducing a typical slow fast AVNRT. So, and this is the tachycardia that was inducible after the first burn. And again, RFA was done in the slow pathway region. And after this, no tachycardia could be induced despite aggressive atrial pacing maneuvers, both from the coronary sinus as well as from the higher RA, with and without isoprenaline, and even after atropine. And this patient is now having a 1-year follow-up with no further tachy episodes. And post RFA, HV is around 47 milliseconds. So I just want to tell very few points about this patient. So as we think, we all know that AV node is not a simplistic right-sided structure. In fact, it is a structure inside the atrioventricular part of the septum, which separates the left ventricle from the right atrium. So it can have various inputs from the right side. Very, very rarely, it can also have inputs from the left side also. So we all know how to understand presence of dual AV node physiology. The commonest one is being abrupt age jump of more than 50 milliseconds with A1, A2 decrement of around 10 milliseconds. Very rarely, age jump may not be seen, but in such patients, it is suspected that if the age interval itself is more than 200 milliseconds, or when we do a decremental atrial pacing, if there is more than 50 milliseconds increase in age interval, then also dual AV node physiology is apparent. At this point, I don't understand abrupt change in slope of AV nodal conduction curve. This is one of the criteria they were given to elicit or to understand the presence of dual AV node physiology. This is especially in children. Sometimes in children, age jump may not be seen. And we all know that double response is one of the markers of dual AV node physiology. Single atrial beat having a dual ventricular response, one via the fast pathway and one via the slow pathway. And when PR is more than or equal to RR and presence of AV nodal echoes, all these suggest dual AV node physiology. Though dual AV node physiology is commonly present in more than 85% of the patients with AVNRT, absence of dual AV node physiology will not rule out AVNRT in a very minority of patients. And a rate-dependent aberrancy can occur both in the right bundle branch as well as in the left bundle branch. And patients with AVNRT, in my patient, the HV to start with was around 54-55 milliseconds. It was borderline prolongation. One relevant point is that if patients have a coexisting intraventricular conduction disease, and if patients throws up an episode of AVNRT at such a high, faster atrial rates, patient can develop paroxysmal AV block. So one of the causes for paroxysmal AV block is atrial arrhythmias, including atrial arrhythmias and AV nodal dependent reentrant tachycardia. And these are the criteria to show different types of AVNRT. We all know this. So in my patient, the initial tachycardia, I think, is fast, slow type of atypical AVNRT. The earliest activation was near the CS ostium, and the H interval was less than 200 milliseconds, and H by HA ratio was less than 1. So a few points regarding fast slow AVNRT. During tachycardia, the H interval is usually less than 180 to 200 milliseconds. And during the long RP tachycardia, inferior leads classically show inverted P waves. And at identical cycle length, the HA interval during ventricular pacing is usually longer than during tachycardia. Also, H interval during atrial pacing at tachycardia cycle length is usually longer than H interval in tachycardia. I have shown that in that slide. H interval during identical atrial pacing rate was longer than H interval during tachycardia. And in all atypical AVNRTs, we have to do almost all the maneuvers to rule out other tachycardias like AVRT and atrial tachycardias. And one more maneuver which I have left is differential RV pacing, which I have not done. That is also one of the useful maneuvers to rule out presence of accessory pathways. So thank you.
Thank you so much, Dr. Velu. I think this is open to discussion, and
Vivek, can you just start with some points? Do we have any questions? I don't see anything on the.
Yeah.
Can you sort of start the ball rolling?
Yeah. So I think the first thing is that Dr. Velu, what you described as an APC, which started the second time the tachycardia, that is definitely an APC only because, as you can see, the lead 3 was showing a positive P wave. So it is definitely not an echo beat. It was an APC, as you rightly mentioned. Can we go back to that slide, please? No, just go back. Yeah. So that clear cut, if you can see lead 3, there is a positive inflection of the P wave. And so this is an APC and not an echo beat. So the main thing, and yes, you're absolutely right. AVNRT is if you are getting a narrow QRS tachycardia with demonstration of both type of aberrancies, then as far as I understand, it is more likely to be an AVNRT. Now the question here is, why were the rates different in the LBB type of morphology and the RBB morphology and the sinus rate? So do you have any comments about that?
No, sir, I don't have.
Yash,
During
can I
LBB aberrancy, it was slower than during
Yeah.
RBB aberrancy and during
Yeah.
IHRS.
Yeah,
Yeah.
but
Can I get your comments, please? Hello.
are you asking me, sir? Yeah. So
Yash,
see.
I want Yash to. I mean.
Yeah.
JP, yeah. No, I first thing Velu has shown whatever illustrations he has shown are very crisp. But as JP, and needs to be commended for the presentation. But as JP said, this would have been even better if we had further maneuvers. One which Velu yourself you mentioned, you didn't have differential pacing. Second, I would have also liked to give adenosine and see what happens. Third, with the second tachycardia, also I would have liked to see maneuvers. You have assumed that the second is typical AVNRT. I would have liked to see that the A on V tachycardia, what happens with BOP. I would have liked to try to price out the A to make sure that the A is earliest and measure the HA interval of the second tachycardia. So while it's a good presentation, I think it could have been even better had you done these further simple maneuvers. As far as the cycle length with left bundle, right bundle, and narrow QRS, this would be relevant if it is during the same ongoing episode. If it is during different episodes, I don't think we can draw conclusions from.
Correct. So yeah, so that's what
This
I
happened
was
at different
going to.
times.
Dr. Vanita wants
Yeah.
to
So
comment. Dr. Vanita is going to comment on anything. Vanita?
No, I think Vivek was saying something. Vivek, you were mentioning?
yeah. So what I was saying was that because this was done at different times of the study, the autonomic influences and whether some vasoactive substances were infused, this will all make a difference in the rate of the AVNRT. The second point I wanted to mention was that after your first ablation, the second tachycardia could also have been kind of a AT coming from the triangle of Koch region. So usually they are a little bit slower than the clinical tachycardias, but that depends on whether isoprene has been infused or no. And probably atrial overdrive pacing is a good way of seeing the response of AHHV or A response, whether the second tachycardia induces actually a lab induced tachycardia or it is a part and parcel of the original disease.
Can I make a couple of comments?
Yeah, please go ahead.
Yeah, so one thing is that this tracing, this is a very interesting tracing, and I don't agree that this is a positive T wave. I feel it is a T wave because if you see in the first wide QRS beat, you also have the same morphology of whatever T or P wave. So it is, I think, is a T wave, and you don't see actually a P wave there. Secondly, I feel this is a very interesting tracing because the first beat is clearly an aberrant beat, but the second beat, what I believe is a bundle branch reentrant beat. And if it is initiating an AVNRT, it's very unusual. So the other thing is that whenever we have an A on V in tachycardia in today's age, I think we should not just assume that it is AVNRT, typical AVNRT. And the most important differential diagnosis that we should differentiate, especially if we have aberrant conduction like left bundle branch block during tachycardia happening, is a concealed nodoventricular, nodoventricular tachycardia, because presence of LBB aberrancy with AVNRT is known, but it is still uncommon. And this tachycardia very well could have been nodovascular, concealed nodoventricular nodovascular tachycardia. The problem is that most of the time it is missed because we ablate in the same region as the slow pathway, and we never get to know whether we are ablated a nodovascular pathway or a slow pathway. Secondly, even if we see the previous tracings during ventricular pacing, the earliest atrial activation is not in the His region. It's actually in the coronary sinus os region. If you see any other tracing where you see ventricular pacing, you see that the His A is quite late, and the earliest is in the CS os, and His A is actually quite late. Not even late; it is quite late.
It can happen in fast, slow, or slow. Atypical AVNRT, this can happen, no, sir?
Yeah, it can happen. So you need to differentiate it from concealed nosoventricular pathway tachycardias. That's my point. I'm not saying it is not AVNRT. It may very well be an AVNRT. Thirdly, the classification of AVNRT, what you have shown is not one which we typically follow now. There is always a confusion in the classification of AVNRT because there are two different opinions. What Jackman believes and classifies as AVNRT is based on your retrograde earliest activation. If it is CS-OS, the retrograde limb is slow pathway. If it is the fast pathway region, then it is fast pathway, irrespective of AH and HA intervals. Whereas Josephson's classification is a different one, which depends on AH and HA intervals. So the latest classification is just says slow fast and atypical. Typical and atypical. Atypical could be anything, but it is all in the nomenclature. I think we should worry too much about the nomenclature as long as we understand that it is AVNRT and we have to ablate the fast pathway region.
Yeah, so I agree with Dr. Karthik, with obviously all these comments. You can still have earliest input back into the CS-OS, even in an AVNRT. Dr. Deepak Padmanabhan has asked, wouldn't the catheter in the FP have given the answer to the type of AVNRT? And yes, it's true. Usually his catheter is taken as a surrogate because it is believed that his is getting activated at the same time as the fast pathway. Any more questions?
No. Can I now intervene, please?
Yeah.
Hello. Now, few comments, Dr. Vadivelu. The most important thing is the problem is created not because of anything, but you have to show what is the fluoroscopy of the catheter positions that you had. Okay. Now it depends on how far your coronary sinus catheter was there. Number one. Number two, you do not have a high rate atrial catheter. So the problem, as Dr. Warren Jackman says, which I truly believe, is that we are trying to sort of do away with some of the catheters. The problem arises because of that. Number three, can you just go back to the last slide which you showed? A very interesting comment which Kartikeya Bhargav came out with. See this. Now, if you see, I don't know whether you see this thing. The last one, actually you see a P wave in lead 3. Can you see that? It's positive. Can you see that? Up, lead 3. After that. There you are. Is it positive or negative?
Looks biphasic to me, sir. Predominantly positive, sir.
Predominantly positive, right? So if lead 3 is predominantly positive, what is happening?
No, JP, sorry. I agree with Kartikeya here that same complex is seen on the previous thing also where there is no P. So Kartikeya said that's more likely to be the part of the T wave, and it seems plausible.
No, it is plausible, but you see the activation sequence changes immediately after that. You see the CS activation is not the same. Now tell me, Dr. Vadivelu, whether your CS 910 is the proximal CS or distal CS. It depends on how you look at it. So if
So
you're
910 is proximal.
some people put 910 distal. So that's why I said fluoroscopic position and identification of this is very important. And also how far inside was your CS? Was your CS 910 away from the coronary sinus os is also very important. Actually, when you're doing your, this is something which I want to, for the juniors, I want to say, when you're placing your CS catheters, it's very important to look at it in the LAO view. In the LAO view, your his should look LAO 40, your his should look directly at you. Number two, your his 10 catheter, the electrode should be in line with the his. Then you are straight away in the coronary sinus ostium. If you have it anywhere displaced, you have all problems. The third thing, please put a high RA and get all your electrograms. It gives you the most important information, and especially if you are in difficulty, it's very important to have more electrograms and more maneuvers rather than saying that just look, this is an AVNRT, I'm going to do a slow pathway modification. It could even be a sort of posterior accessory pathway which you would have ablated, which is associated with something else. So unless we prove it, we can't say that. And you have to realize that AVNRTs can have many manifestations. One is it can be the fast slow, the slow, the slow intermediate, isn't it? So we need to have a lot more maneuvers which are done to show us that this is an AVNRT and we have not done something which is unusual. Am I okay?
Yes, sir.
So when you are in difficulties, I always tell, please put in more catheters, do more maneuvers, prove it that it is there, and then go ahead. And in your situation, you probably have done it, but you see the activation sequence is slightly different. So I would be slightly worried. And my cause of worry is not because of anything, It could be a left postroceptal accessory pathway. And many times when you're doing an ablation in the RAO, it would have gone into the coronary sinus and you might have ablated that pathway and sort of change the activation sequence. Right? It's a possibility. Why? You have to answer one simple question. Why did left bundle branch block? Why did it slow down the tachycardia? That is one simple thing which sort of confuses me. It should not do in a tachycardia. It is illogical for that to happen, isn't it?
Yes.
So if it is whether it's a right bundle branch block, whether it's a left bundle branch block, an AVNRT tachycardia cycle length should not change if you're doing it in the same autonomic thing, because the autonomic balance at that time is the same. And you must have done this maneuvers within a space of a few minutes, or you must not have taken hours together where the autonomic balance has changed, isn't it? So always I think of these small things. Why should this tachycardia with a left bundle branch block become slower? That means, am I missing something?
So that
left
bundle branch tachycardia was.
Assumptions are different, but for me, I deal with facts. That's all I'm saying. Because we are in a scientific form, I'm trying to bring out this thing. So what I'm telling you is, you have done a good job, fantastic presentation, but nevertheless, the message is that we need to do good maneuvers to prove that we are not missing something, and not saying that a tachycardia is a default, AVNRT is a default diagnosis for this. Because the activation definitely changes, like Kartikeya Bhargava says. And even here, there is a change in the activation sequence in the 2 beats. Right?
Yes.
So that's all I'm saying. I'm just bringing out certain points of interest which should make us, contemplate on whether I'm missing something. Am I doing something by default? Is it my? So I always say that don't do things by default. That's what I have been taught. Don't do things by default. Question yourself. Why is this tachycardia with a left bundle branch block become slower? You give me one answer for that. AVNRT, whether whatever form of AVNRT is there, it cannot become slower. Right? You agree with me?
Yes, sir.
That's all I'm saying. It's not that I'm criticizing you, but it's something which truly, it's what we should truly look at as a scientific community when when we present and when we do certain things, we have. That's why what we do is called electrophysiology. It is not intervention. Intervention is different than electrophysiology because we're dealing with physiology. Correct? Wonderful presentation.
The only thing is I should have done all the manuals again after this A1V tachycardia.
No. But tell you what, never ever forget to put the high right atrial catheter. Do not cringe, when you are in a difficult situation, get all your electrograms in. It makes so much of a difference for you. And see that they are in the same position. For me, in my lab, we put all these catheters along with the high right atrial catheter in the appendage. And my mind is only, I can't do with less catheters. I do not do it with less catheters. And this thing is that I have to place these catheters in this way. That is, the his has to look to me in LAO. In LAO 40, the CS10 should be aligned with the his. Then I know I'm quite fine. I'm in the septum. If it is too far in, it's different. If it is too far out, it's different. And especially in a difficult situation, please believe this. This is something which I have been taught by John Calvin. It's not my own. Okay. Fantastic presentation, but I think it leaves some.
So Dr. Velu, I think it's an excellent presentation, and the demonstrations, I think, at least I think that, yes, there are more maneuvers, but I think you've done sufficient in one case to probably the second tachycardia, you may have done them all over again. I'm sure you must have done few of them again to see that. So thank you so much for your presentation. And can we have the next presentation by Ajit?
Yeah.
Yes, sir. Thank you, sir.
Yeah.
Hi, Ajit. Can you start your presentation? Yeah, thank you.
Putting the first slide up here. Okay, so there are 3 cases here. Depends on the amount of time. I want to discuss the first one thoroughly, and the other 2 are just small things which I want to mention. Okay, is the screen there? It should be there.
Yeah, we can see your screen. Yeah.
So I titled this presentation "The Thief That Stole from Under My Nose." So this is a 55-year-old lady who had complete heart block and had resuscitated bradycardia-induced VF. She came in with brady with CHP. She actually had a narrow QRS CHP. She was in the ward, and she suddenly went into VF, and she was resuscitated, put on a ventilator, intubated, and angiogram was done. It showed normal coronaries, and we put in a dual chamber pacemaker. It was a biotronic extrinsic DRT, and these were the parameters. The PA was 2.5. Thresholds were 0.8 at 0.4 and 0.4 at 0.4 and 0.8 at 0.4. This was the impedances. This is a echo immediately after the pacemaker. There is some hypokinesia, as you might expect, because she's just been resuscitated. But I kept a note of this saying that, okay, this is not a completely normal echo. She needs a closer follow-up than usual. So she came for follow-up in May. In May, this is her echo. could still be passed off at normal. It was passed off as normal. And the parameters were virtually unchanged. She was perfectly fine. She had a p-wave of 2.1. The atrial threshold had gone up from 0.6 to 0.4 to 0.6. The ventricular threshold had gone up from 0.8 to 1. The impedances remained largely unchanged. The atrial impedance was almost the same. Ventricular impedance came down by around 100 ohms. But this was there. There was one episode of non-sustained ventricular tachycardia lasting 6 seconds in the pacemaker interrogation. The rate was 191 beats per minute. I didn't take much notice of this because at this point she had a normal echo. She was asymptomatic. This had been the only episode of non-sustained VT. And in general, pacemaker-induced non-sustained VT is not, thought to be a bad thing in otherwise normal heart. So there's a lot of literature about this, but this is probably the best paper on this. There's a long-term follow-up of ventricular high rate events detected on remote monitoring. So the data is complete. 23% of the patients had ventricular high rate events and 16% were true ventricular high rate events. The mean rate was 194 beats per minute, and the usually it was just 5 seconds. The mean duration was just 5 seconds. And there was no difference in mortality between true VHRE, false VHRE, or no VHRE. No difference in requiring device upgrade. No difference even if the EF was less than 40%. Where the EF was less than 40% or more than 40%, VHRE detected on pacemaker did not mean anything. Others have also done similar analysis. One analysis says that if the VHRE is more than 250 beats per minute, that portends future requirement to device upgrade because the LV function might reduce, but not if the VHRE is less than 250 beats per minute. So all this put together in a 54-year-old lady who was asymptomatic, I just left this alone. On December 21st, that is, so this was in March. So 9 months later, she comes complaining of fatigue. When she comes complaining of fatigue and she's admitted, this is the ECG. We can see that the P waves there are being tracked. After each P wave, there is a pacing spike. But the pacing spikes are universally not capturing. The ventricular pacing spikes are universally not capturing. We can also see that some of the pacing spikes are following after the QRS complex, which means that there is no sensing at all. So this pacemaker is, the atrial channel is sensing. The ventricular channel is neither sensing nor pacing at the output that it's programmed. The output was programmed to 3.5 at 0.4. Auto capture was on, but as you know, the limit of the auto capture is 5. And this was the impedance. The impedance was fine. Atrial and ventricular impedance was 565 at this time. Atrial bipolar 565, ventricular bipolar 565. We can notice that in the trend that somewhere about 3 weeks before this, the patient had started getting a little sick. The patient activity had started reducing somewhere around here. This, if you look at the date, this is where the end of November. This is end of December. So this is a 1 month scale. So about a month before this, so this is the 1 month scale. About 1 month before this, the patient activity had started decreasing, suggesting that something had started going wrong about a month before this event has happened. This again, the thoracic impedance, which came down about half a month before this event, which means that probably some heart failure started settling about half a month before the event. So something had started about 1 month to half a month before the event. This was the last possible threshold measurement. So this was 1 month before the event. So this is the auto threshold measurement trend. At this point, the threshold measured was not stable, was more than 2.5. It stops measuring once the threshold is more than 2.5. So at this point, it could no longer measure the threshold. So it stopped measuring the auto threshold of the ventricle. The atrial auto threshold is measured. So something has started happening 1 month to half a month before the event. And the lead impedances were by and large normal, except a small terminal drop in the lead impedance here. But I don't think that's really dropped to a really bad value because it's still 565. It had dropped from the initial 740. In the last few weeks, there was a drop. I agree, there's a drop of around 100 to 115 ohms, most of which happened in the last 2 weeks prior to the implant. The RV capture control had been disabled on December 3rd because it was way out of the range of the capture control range. So the RV so it had probably lost capture on December 3rd, and the patient has presented on December 21st. So we checked the pacemaker. There was absolutely no sensing at a sensitivity of 0.5. There was no capture at an output of 7.5 and 1.5. And there was no macroscopically visible lead dislodgement. So what are the possibilities? Well, the first possibility we think is micro dislodgement, and another possibility we can think is perforation. Just the tip could have perforated and the ring could still be in contact, or the tip and the ring could have perforated and the lead would still be there. But at least there was absolutely no macroscopically visible dislodgement. We also had a lengthy discussion with the company on what else could be there, where the pacemakers, the ventricular channel is giving an output, but it is not sensing, and it is not sensing and not able to pay. Of course, another problem could be that some problem happened to the myocardium, which has happened in the last 15 days to 1 month. The third possibility which they said is that, well, if you have a break in the conductor within the blood pool in such a way that the outer coil and the inner coil come in contact with each other, because there is a conductor, there's an outer insulation break and an inner insulation break. This must happen within the blood pool is what they said. And blood seeps in within that break. They said that the blood can complete the circuit there. In that point, the impedance inside the pacemaker is the only impedance left. So they said this is also possible, because apparently the impedance in the blood is around the blood tissue interface impedance apparently around 100 to 150, and the rest of the impedance is in the pacemaker. So this was I have not heard of this before, but these are the possibilities I kept in mind. So the first thing that I thought is I'll open up the pacemaker and go for an implant, keep all these possibilities open. Now this is the echo when she came in December at this time. Well, you can see that the LV has become severely hypokinetic. The severe LV dysfunction, and of note, the septum looks a little thinner than what it used to look before. Septum does look a little bit thin now, and there's definitely severe LV dysfunction. So this is just before we took her on table. There was a stenosed vein which was crossed with great difficulty after a tiny wire across and dilating it. And I put a long sheet, the CS guide across, so that subsequent lead deployment would be easy. Now, to my surprise, the R waves were 1 to 2, or sometimes even less than 1, or sometimes unrecordable throughout the interventricular septum, which was entirely normal in the previous implant. And most places of the interventricular septum could not capture, and the places which could capture also had a threshold of 5 at once. So obviously there was an issue with the myocardium. I also checked the possibility of tip perforation. Neither the tip nor the ring was capturing. So one possibility was that the tip had just perforated and the ring could be in contact. There was the tip impedance and the ring impedance was the same. And there was no capture from the ring electrode also. So finally, I came to the conclusion that something has affected a myocardium, and this particular something has affected the entire septum. And finally, I put my lead in the RV apex. I put a tine lead in the RV apex with a R wave of 5 and a threshold of 0.7. So that's the final thing. I didn't try to remove the active fixation lead because it was strongly adherent here at the SVC RA junction. And the last thing I wanted was to get this lead dislodged when I was trying to get this out. It was with great difficulty that I finally found a spot from which I could pace. So now what has happened? I did a PET scan, and on the PET scan, most of the anterior wall and the interventricular septum had minimal FDG uptake with an SUV of a standardized uptake value of 2 to 5, which is basically minimal amount of inflammation and absolutely no perfusion. There's total perfusion defect in the entire anterior wall and septum. And the gist of the PET scan was abnormal mismatching increased FDG uptake corresponding to perfusion defects in LV myocardium in the apex, anterior, anterior wall, septal, and anterolateral segments, suggesting active inflammatory pathology, likely advanced active cardiac sarcoidosis. Now, this patient did not have inflammation in any of the other organs. There was no lymph nodes. So if it had to be diagnosed, it had to be diagnosed as isolated cardiac sarcoidosis. Now, even if we go by the Japanese criteria, this still doesn't fulfill the diagnostic criteria of isolated cardiac sarcoidosis. For that, we also need an MRI. I didn't do an MRI in this patient, but it would fall into the category of probable cardiac sarcoid. So I said, okay, probable cardiac sarcoid. I did not do an endomyocardial biopsy because I think, considering this clinical picture, endomyocardial biopsy is unlikely to be very, not likely to be very useful. I put her on empirical steroids for whatever it is worth. I had also suggested an upgrade to CRTD, but for the main reason being financial, the patient declined the upgrade to CRTD. And today the patient came for follow-up. Oh, where's this? So this is basically what I say. The pre-treatment myocardial FDG uptake. This was recently published by Narasimhan's group. That if the pre-treatment myocardial FDG uptake is very low, that is less than 5, there is likely to be poor response, or if there is no uptake, there is likely to be poor response. But anyway, she was started on steroids. She came for follow-up today, and this is the echo. Doesn't look very good. It's got worse than December. The entire septum is gone. It's totally thinned out and scarred. And here the entire septum is gone. Worse, this patient, this is the ECG. This patient is in VT. I just cardioverted her half an hour back. She just come. She was very sick. Her EF is 20%. She is in ventricular tachycardia. Now, the myocardium has been stolen from under my nose. I don't know what could have helped. What else could have been done for this lady? Except maybe if she was on remote monitoring, we would have picked up that something is going on in the first half of December. Beyond that, I really don't know if anything could have helped. And I don't know if something could have been done, even if we had picked it up on that day. This is a disease which has just somehow started at the beginning of December, and by the end of December, it's killed a myocardium. That's why it said stolen under my nose. I don't think she was not under follow-up. She was under reasonable amount of follow-up for a otherwise, lady with no comorbidities getting a pacemaker. So I would like some discussion on this before I can go to the other two very small presentations.
Vivek, do you want to sort of start the proceedings?
Sure. Yes, sir. So I think this is it's a very intriguing case. The sarcoid bit is not very clear to me because the uptake was not there in the septum at all. This was, I think that would correspond to severely fibrotic place, and whether the question is whether at the time of presentation as a complete heart block, whether that was a time when she was having some active disease and whether this is just burnt out now in that sense. I can't think of anything more which you could have done from the beginning in this patient. But I was wondering whether when you were putting the thing, whether one may have considered an endomyocardial biopsy at that point of time.
At the time of putting the second pacemaker. Yeah, I considered the main reason I didn't do it at that time, the patient was really sick. You can imagine how sick that patient would have been. And I thought it would probably have a low yield.
Correct. So, yes, so I agree that, the yield, I can't say really, in the sense that probably in terms of doing something for the patient, it may not have really helped you beyond what you've already done. But such a rapidly progressive myocarditis, I think I will give the floor to more experienced people like JP sir, but whether kind of a giant cell kind of a picture which is more progressive and very rapid as compared to sarcoid is something we can consider in this patient. What was the age, by the way?
54.
Yes, 55 years.
Yeah, so
Right.
So it's in India we do see a lot of CHB at this age, but typically this is a bit decade younger than the normal people.
I just like to mention, I've not put it here, but a year before that, I had a 51-year-old lady with CHB, intermittent CHB. That's an even more interesting thing. She actually had syncope, and then she underwent a coronary angiogram, like a lot of people with syncope do. And she had a left main bifurcation disease plus a circumflex plaque. And syncope was like total collapse, sudden total collapse and then recovery. Her ECG was subsequently normal. She underwent a CABG. Post CABG, while she was in the CT ICU, she had a syncope again with all P waves and no QRS complexes. So I said, okay, at this point, her LV is normal, everything is normal. So I told her, okay, maybe you have paroxysmal AV block. I'm not sure what you have, but you have syncope. Your syncope is not due to coronary artery. I put a single chamber pacemaker. 1 month later, she comes with severe LV dysfunction, very similar picture, 51-year-old lady. Here, I had uptake in the little bit of uptake in the septum. I had a node. I biopsied the node was sarcoid. I treated the sarcoid with steroid, but once again, the horse had bolted because the LVEF was low. Then she had VT. She was resuscitated from VT. She's on a CRTD. She's not doing very well now. And that's another 51-year-old lady whose first presentation is CHP. So I don't know what else is to be done.
Ajit, if I may come in here, Ashish Nabar here. Sorry for joining late.
Ashish, have you finished your pacemaker, man?
Yes, yes.
I hope it's not a complex sarcoid. Don't lead in the septum again, huh?
Yeah, a little older patient. No, so one question for Ajit is, in this younger patient, should we have some kind of a protocol to, image?
That's what I'm trying to say. Maybe it's a question of how young do you start suspecting that, it's something more than a run-of-the-mill thing. And if you suspect, what are we going to do? Maybe you might say, 55-year-old lady is somewhere on the borderline. It's not too young to have a CHB. The first lady was okay. The second one is 51-year-old lady. But how young do you start beginning to suspect that there is something
Yes.
going on?
Yes, difficult question. Again, would you have put the lead in the CS and done a LV pacing, or would you, while you were struggling with to find a good place in the RV?
No, because she was completely pacing dependent. She had bradycardia-induced VF. I wanted to have a reliable pacing. And that lead in the apex, I looked at it. I was quite confident that the lead in the apex would stay. The way it was there in the apex.
Yash, can we get some inputs from Yash and Kartikeya Bhargava?
Yeah, I actually put my comments, Ajit. A couple of things. One is the ECG when the patient comes with, of course, initially also the septum did look abnormal, but patient was doing well. So it is, what you did was fine. But the second time when the patient came with CHB, the ST elevation certainly suggests an inflammation. They are not a memory sign ST segments. And one would have straight away gone for a PET CT and maybe with a temporary wire in place, hit harder, not just, and doing an endomyocardial biopsy, frankly, is not Ajit, you've done so many. It's not a big deal. Because since the entire septum was involved, picking up something, as Vivek said, giant cell, which is a very bad prognosis. But here, giant cell, if we started off with giant cell 1 year down the line, suddenly manifesting like this is also unusual. So it could well still be an unidentified simmering myocarditis or isolated cardiac sarcoid or a giant cell. All this could have been better clarified with a biopsy because the entire septum was involved anyway. And then maybe with a temporary wire in place, you could have hit much harder than just steroid. Hit much harder because you got to be very aggressive, especially with giant cell. And for all you know, after some time, the thresholds may have come down and your original septal pacing lead may have paced again. I've had a girl of about 30 with symptomatic CHB. 4 years back, I had put a dual chamber pacemaker. After investigating fully, there were some areas of inflammation, but no nodes, nothing to biopsy. After 4 years, she came with progressive LV dysfunction and rise in thresholds, and I was advised a CRTD by somebody. We investigated her. This time there were accessible nodes. It turned out to be sarcoid. On steroids and methotrexate, the LV has improved. The thresholds have come down. The leads which were not pacing at 4 volts are now pacing at 2 volts. So I think this could have been one more option of doing a biopsy, doing a PET CT upfront and hitting much harder.
The PET CT was not very late because I put a permanent pacemaker. Next day she had a PET CT.
No, what I mean to say is rather than discarding your septal pacing site and going for an apical pacing,
but I had to.
Get a temporary wire.
Dependent and she has no capture.
Yeah, I agree. So put a temporary wire in the apex. and do a biopsy and then take a decision.
Okay, okay.
Okay.
Eventually, the septum seems to be much thinned out and scarred. So,
So
would this have would the septal pacing lead would have eventually worked, or
no.
seems
So let's start with the basics. Let's start. So can I see the second slide, please?
Sure.
I think all of you are fantastic echocardiographers, and I'm basically, I don't do echocardiography these days.
Yeah, there's the second slide.
I can't see. Can
Okay, I need to put on screen sharing. Just
screen sharing, please?
One learning point is that in
No,
patients.
just wait. Just
slide.
wait.
The LV does not look normal on the second slide.
No. I just want the previous slide. The previous slide.
The first slide. This is the second slide. This is the
this freeze that.
Yeah.
Freeze that. Now just see the septum. What is it showing?
Normal. It doesn't look normal. It's a hyperechogenic thick septum.
Hyperechogenic. When you see something like this, okay, these are subtle signs. You are a pandit in sarcoidosis, boss.
That's why I did the
Complete in JSCC, boss. This gives you the clue that you are missing
the repeat echo at 1.5 months.
I caught this in the first slide, and I put a message to Vanita Arora that this is the diagnosis.
I told it myself. I told it this.
No, you have missed it in the. See,
maybe because the patient had a prolonged
no, my friend. Every single small thing counts. Every single small thing counts. In medicine, there is nothing like all or none. There is nothing like you can do something, this thing, especially in electrophysiology. I believe that it's a very precise science. The problem with people is that I think I'm too precise. No, I have been taught to be precise. We are missing things. You are a pandit in sarcoidosis. You should have picked it up straight away.
I thought it was abdominal. I told that in my presentation.
Yeah. Now I'll tell you what. Tell you what. We have got now about 20 or 25 of these patients whom we have got with only AV block. We are going to publish that. So,
but how long did it take for the LV to become abnormal?
Oh, they can go from normal to abnormal within no time. Yeah, you should know about it. You are a pandit, man. You have published it.
From normal to abnormal in 2 weeks.
Oh, it can.
9 months.
And second thing, let me tell you, Ajit, just think about, all of us do not think. We think about cardiac sarcoidosis in a different way. You will never get, where does the sarcoid occur? It's in the mid-myocardium. Right?
Yeah.
So why are the biopsies so low, this thing, in giving you this?
Yeah, that's because it's an endomyocardial biopsy.
Endomyocardial disease, that is the problem.
No.
The West, I'll tell you, the problem is in the West. In the West, they have burnt out cardiac sarcoidosis.
True.
Okay. So here, there is an isolated cardiac sarcoidosis.
Right. This is isolated.
This is isolated.
Right.
And we have got now about 140 of these patients now. We are going to write it up, which is now, we have got, of that, we have got about 25 with complete AV block only. And the most important thing is not to miss these subtle things.
But sir, why would that hyperechogenicity disappear at the follow-up echo?
It doesn't matter. It has given you a clue. It is burning itself out. It has told, look, I am there. You have said, look, I am ignoring you. And you are a pandit. You should know about it.
My point is, at follow-up echo, this hyperechogenicity had.
No. I'm not worried about what is the follow-up. No, I'm not worried about follow-up echo, Ajit. The problem is you have missed this.
Yeah, true. Absolutely true.
It is not stolen under your nose.
Yeah.
It is not stolen under your nose. It has told, my dear friend, I am here. You are a pandit. Correct?
Agreed. I
So
thought it was
stolen under your nose. It is said that, look, I am here. You have missed me. You are a pandit.
Look at the IAS. Look at the interatrial septum is also thick.
Look at that. It's like hypertrophic cardiomyopathy between not only inflammation, it is edema. And would you just let me, for example,
yeah,
you try to do an endomyocardial biopsy here. I don't know whether you can see my, this thing outer surface. How can you pick up, sarcoid?
Yeah, we know about that part.
Right.
We know that the endomyocardial biopsy.
The great stupidity of all these endomyocardial biopsies, which I don't realize, accept.
I don't think anybody in this forum advocates endomyocardial biopsy as a great test for cardiac sarcoid. I don't think I think we are all clear about that.
Never ever do an endomyocardial biopsy.
I think all of us agree on that.
No. See, it's a mid-myocardial disease. You can't get a mid-myocardium in endomyocardial biopsy.
Absolutely. So the question is, I'm just going in the chat box. There were some comments from the US saying that Abhishek and someone else saying that investigate all patients.
No.
Under the
Ajit, let me put some of this in perspective. Okay. Now, when you have a burnt out sarcoidosis, it's everywhere. When you have isolated sarcoidosis, which is early with a normal LV function, it is mid-myocardial. If you miss that, then it becomes everywhere. Okay. Then you do all this EGM guided. Why EGM guided? Because you have missed it. Your EGM is gone. The myocardium is gone. So naturally you have to do EGM guided. By that time, you are not going to do anything great to the patient, right?
It's bolted. By the time it's all over. So you're saying that once I see this, I should have done a PET.
Yes. See, even in echo, it gives you a hint saying that, look, I am there. It always says, it gives you a hint. Now we have got 140 patients which we are following up, and 25 of them have been isolated AV blocks, which is very surprising. And this is a very subtle hint which says that, look, I am there. It says intratracheal septum is thick, intratracheal septum is thick and hyperechogenic. And if you see I had this circulation article on bidirectional VT in a patient with cardiac sarcoid, which is probably the only article which discusses about a parasystolic VT in sarcoid. It's a parasystolic VT because there was a parasystole between the septum and the lateral wall. And I think Bill Stevenson and Ashirvatam wrote a editorial commentary on that. So it is a very funny disease, very difficult disease to catch, but it gives you subtle clues.
So
echo is good. You pick it up.
In which patients of isolated AV block under the age of 60 would you recommend workup for cardiac sarcoidosis and how?
So we have now become very, very sensitive. We look at something like this on echo. We send them for PET CT, not MRI, even with a temporary pacemaker.
Agreed.
Okay. So you pick something like this. You don't send them for an MRI.
Yes.
Send them for a PET CT.
That part is clear. Once you suspect, we know we didn't.
It is not suspect. I mean, this is quite obvious. There is a difference between suspicion and obvious.
Okay, agreed.
Okay, there is a subtle difference between.
Yeah, I was just fooled by the follow-up echo. I saw this. I knew it was not normal, but I suspect.
No, look at this. Look at this. You can't see. There is wall motion abnormal. Run that down. Run that. I like it.
No CPR. This is after 20 minutes of CPR.
Then that's okay. That's okay. But you can't. It's not infarcted myocardium, boss.
I agree. No, I agree with you. I also suspected it. It is just that when I saw this on follow-up, I said, "Oh, well, maybe I was wrong to suspect." So that's why I missed the boat, I guess.
Okay.
I think, Ajit, both your echoes are showing actually scarring in the septum. And that scarring could be because of anything.
Now, see, really. What has happened in the next thing is, I'll show you. Now, see this echo. The inflammation has subsided. The thickness of the septum has decreased.
Has reduced a little bit compared to March. You're right.
Because
That's right.
It has just reduced a bit compared to 2 months back.
that is the, and you should have compared your previous with this and said that, look, I'm missing something.
Yeah, I think you're
You
right.
should not gone back behind the
Definitely
joint.
reduced a little
You
bit.
should have said that, look, there is a myocardial problem.
Yeah, I think you're right about that. Compared to the previous echo, this is about 2 mm less in thickness.
Yes.
And a
You
little
should not
less
have discussed with the
compared to-
guys about various things in the device, but you should have said, look, I've missed something.
JP, we should look at the ECG also. Simple ECG is
No,
extremely
more than
unusual.
simple ECG. The first, see, ECG is much farther down the line, isn't it, Yash? ECG is much farther down the line.
Yeah.
I agree. I'm
Only
just saying.
ECG presented is in December. By the time it's gone, it's like
gone,
a big ST elevation because most of the area has become aneurysmal.
By the time you can't do anything much to this patient. It is not the disease has stolen under your nose. It has said, I was there, boss. You have missed me. You are a big sarcoid boss. Look, my friend, I can beat you.
Well, yeah, agreed.
Agreed?
Yeah.
Okay. I think we are. I think we are down the
I'd
line.
like to show 2 more equally intriguing things.
No, too much. What time is it? It's already 9:15, man. We'll go for the next session.
The next session is my next case.
No. We'll go for the next present. Next time. I have to go for my dinner. Yeah, it's 9:15.
All right. Okay.
It's the interest.
I'll save it for later then. These 2, but very short ones. Just 5 minutes.
But for me, it will take 10 minutes to decipher it.
Yes or no?
I think we can reserve them for the next time.
We'll present it next time, man. Next
Okay.
time. Present it for the next time.
Yeah.
Thank you.
Thank you.
Wonderful, fantastic cases, fantastic teaching points, beautiful cases. Absolutely. Anybody in the participants wants to ask question or have some doubts? Can we get some inputs from the chats?
Yeah. So Suchit had asked a question whether this could have been a laminin kind of cardiomyopathy.
Oh, come on, man. I mean, Ajit, when you have something on the echo which stares at you and tells you, look, I'm there, and kicking you at your balls that I'm there, you don't look for something which is right. Suchit.
It's 9:15. So thank you, Ajit. Thank you, Velu. And thank you, Ashish, for finally joining us. Thank you, Vivek. Thank you, Dr. J.
You're welcome. Good night, all.
Ashish is there.
Okay, you're not thank me, man.
I said thank you, Dr. JP. So Dr. Yash is there. I would request again, for everybody, kindly keep your mics on mute. It is very disturbing.
It's very disturbing
and in between
today. Yeah.
there is some background noise going on.
No. Whenever a person is talking, keep the mic on. Person is not talking, just, keep
During
it.
the presentation, it should be